Today we have Dr. Alex Ellswick. He's a tireless advocate for people with substance use disorders, and he serves as an assistant professor and extension specialist for substance use prevention and recovery at the University of Kentucky. Thank you so much for joining us, Dr. Ellswick.
Thank you so much. And I'll go ahead and bring up slides right now. Well, first of all, it's good afternoon from me. I'm in Kentucky. I don't know what time it is where you all are, but good to be with you all. I'm really glad for this opportunity. One of the things I've learned through clinical work and academic work and just my experience over the last 15 years or so is that not many of us in clinical spaces have really good opportunities to get continuing education. We get the standard continuing education credits, but once you pass out of school, we don't have as many really ripe opportunities to update you on the latest science. And so I'm really glad for this opportunity to be in a space with a bunch of clinicians, a bunch of people who are hands and feet, boots on the ground, whatever mixed metaphor you like. And I think this is really going to be an impactful hour. I'm going to do my best to keep it to about 50 minutes or 55 minutes and leave a few minutes for questions. But I'm going to move quickly because I got a lot I want to share in an hour. So my name's Alex Ellswick. I like to tell people that I'm fortunate that I've had the opportunity to learn about drugs and people who use drugs from so many different vantage points and so many different experiences. So I started my career as a marriage and family therapist. I did clinical work. I learned I wasn't a very good therapist. I'll tell you all in a little bit. I have anxiety disorders, and so the whole notion of sitting in like therapeutic silence in a confined space with a perfect stranger was really uncomfortable to me. So, and I think I transmitted it to my clients, and they walked out worse for the wear. So, anyways, I ended up going back and getting my doctorate, and so I'm an assistant professor at the University of Kentucky, and I have a really cool job because I do traditional faculty work in terms of teaching in a classroom and doing research. My spans everything from emerging adults who use drugs to older adults who use drugs in long-term care facilities to special populations like LGBTQ youth who use drugs and women with perinatal opioid use disorder. So really kind of spans the gamut. But more recently, my research is focused on harm reduction and really harm reduction as a pathway of recovery, which is something that we're going to dive deeply into today. But in addition to teaching and research, my job comes with a third leg that's really interesting. That's called extension, which basically means not everybody's fortunate enough to come to the university to get an education. And so we extend the knowledge across the state and across the nation. And so really this is an example of research translation right here today. In addition to that, I'm also a co-founder of a nonprofit recovery community organization in Lexington called Voices of Hope. And if I had more time, you all, I would give you the biggest shameless plug for Voices. We're not a treatment center, we're a recovery community center. So we're a hub for recovery support services. All of our 90 staff are people in recovery who use their lived experience. That's their main credential. They're not clinicians, they're not experts of any other stripe. It's a really cool space. And so, I've learned a lot of different things from clinical work than I learned from research, and I learned different things from research than I learned from on the ground service provision with people who use drugs and people experiencing homelessness and people who do sex work and the most vulnerable members of our community. But without a doubt, the most important experience I have is personal experience. And that's because I'm a person in recovery from an opioid use disorder. And I want to share just a little bit of that experience. I really don't want to get too carried away and get lost in my own story because I have so much fun stuff to share with you. But I do think it's helpful to have a sense of kind of where I'm coming from and to set the stage for what I want to talk about today. And I brought you all pictures, which makes everything more fun. So really quickly, the short version of this story is I was born and raised here in Lexington, and I was born into really privileged circumstances. And I don't say that to virtue signal. I say that because it's true. My dad's a doctor, my mom's an accountant. Nothing bad ever happened to me as a kid. No adverse childhood experiences. I grew up in the suburbs and went to private school. But that couldn't change the fact that I inherited these risk factors for addiction, risk factors that I certainly didn't invite to my own front doorstep. A genetic predisposition for addiction. My mom had like seven uncles, and four of them had drug and alcohol problems. So my risk was elevated at a young age. But secondly, as I alluded to earlier, I've struggled with anxiety since about the age of 12 or 13. And I don't know if this is a universal experience, but for me, up until the age of 12, everything came easy. School came easy, sports came easy, social interaction came easy. And then all of a sudden, with adolescence and puberty and all that awful garbage, I started to experience anxiety. And to keep this long story short, I ended up, this is probably 17-year-old me. You're welcome to laugh at that wherever you are. Um, there's a real identity crisis going on in that picture. Um, I ended up being diagnosed with three different anxiety disorders. So, generalized anxiety disorder, social anxiety disorder, and trichotillomania. And so, I'm guessing in a room full of clinicians, there's some familiarity. For those of you who don't know, trichotillomania is a hair pulling disorder that disproportionately affects adolescent females. So, usually you'll see young girls coping with anxiety in this maladaptive way, and then they actually start pulling out clumps of hair. And for me, it was my eyebrows. I don't know why, but when I was in the seventh grade, I'm right-handed, so I'd be doing schoolwork, and my left hand would creep up to my eyebrows and pluck and pull and pull. And part of the reason I mentioned that, you all are probably already well aware of the comorbid relationship between substance use disorder and co-occurring mental health disorders. But beyond that, I think it's important to note that even at a really, really young age, I had had the experience of acting against my own will. Like, I can remember sitting on those hard plastic chairs in middle school and physically sitting on my hands and saying to myself out loud, Alex, stop. And I could clench my fists and I could grit my teeth, and for 30 seconds, I could resist the urge, but as soon as I let down my guard, I'd go back to pulling again. And it's so analogous to me of what it was like when I got addicted to substances later in life. Just like my mom would say to me, Alex, just stop pulling your hairs out. Why are you doing that? That's weird, you know? In the same way, everyone around me, everyone who cared for me would say, Alex, why don't you just stop using? You're ruining your life. And I would argue, at least in my own experience, that I had as little willpower over my substance use as I did over my ability to prevent pulling hairs out of my head. Um, so, anyways, I ended up going to college to play baseball, and when I was 18 years old, I had surgery to have wisdom teeth removed, and I got prescribed oxycodone. And I took it exactly the way that it was prescribed by my provider. But it didn't matter because I had all these risk factors, and addiction took me all the bad places that people go. I went in and out of jail on drug trafficking charges. I went in and out of treatment and in and out of treatment and in and out of treatment. Um, and one of the things I want to communicate to you all really clearly is how hard I was trying to stop. Um, I always think there's got to be a more eloquent way to communicate that, but all I know to tell you is I was miserable, and I was experiencing every consequence under the sun, and I wanted it to stop, and I just couldn't make it stop. And I ended up experiencing homelessness in a few different cities, in Nashville, in Cincinnati, in Lexington, and then finally in Dayton, Ohio. This is a Highway 35 overpass that runs through downtown Dayton. I had made the transition from um, snorting, opioid pain medication to injecting heroin. And maybe that sounds like a wild leap, but really they're, on a pharmacological level, they're like chemical cousins. So it was kind of an economic necessity. And I met a community of folks who were homeless and also addicted, and they kind of showed me the ropes. And they showed me where to go to get a meal and where to go to get a shower. And they told me about a Salvation Army, which is a homeless shelter there in Dayton. So this picture is September 13th, 2013. It's the day I checked into the Salvation Army for the second time. I'll tell you the rest of that story another day. It's the start of the worst 30 days of my whole life. Slowly, slowly, things started to change. Things started to get better. I spent 6 months at the Salvation Army, and I wish I could say that that was enough. Because you all, if recovery was meritocracy, if recovery was just all you have to do is work hard and want it, and then you'll recover, then man, I would have recovered a long time ago. But that wasn't my experience. Just wanting it, just willing it was never enough to make it stop. And when I left the Salvation Army this time, I face all these barriers that are really characteristic barriers that people face when they leave treatment and they leave incarceration. Because I've got bad credit, lots of debt, criminal record, no college degree, no marketable skills. Who in their right mind is going to give me a job? You know, I was disqualified from supportive housing by virtue of the fact that I had a drug trafficking charge or conviction. I didn't know where I was going to go. And this is where coming from a privileged social location like I did made all the difference. And in order for me to make this point, and in order to kind of wrap up my story here, let me just compare my experience to my buddy Jason's experience. Jason graduated the Salvation Army with me, but he doesn't have the same family support or the same financial support that I have. So he can't afford a halfway house. He can't afford any type of supportive recovery resident. He can't even afford a one-bedroom apartment. So instead, Jason, when he leaves the Salvation Army, he has to go to the Gateway Shelter in Dayton, which is not the shelter with a treatment component. It's the shelter where IV drug users stay overnight. And we don't have to be a room full of clinical experts to go, my goodness, that's a terrible environment for Jason to try to recover from his opioid use disorder, right? And what I want you to understand about that is that I was spared that. I was spared the indignity of having to continue my recovery in a homeless shelter. And more importantly, I was spared the stress, the really meaningful kind of biopsychosocial stress that Jason had to face on a daily basis, grinding his way out through a homeless shelter. And I didn't have to do that. And I'm telling you all that it's not because I'm better than him, and it's not because I'm smarter than him, and it's not because I wanted recovery more than him, and it's not because I love my kids more than he loves his kids. It's not because I put in some special effort or some special willingness or some special honesty. You know what it is? My dad had a relationship at a church here in Lexington, and the pastor let me sleep at the parsonage for free. Just because I had a connection. You know, it was just kind of a privileged connection. And it's really hard for me to overstate what a big deal that is. When I don't have to worry about making rent, I don't have to worry about getting evicted. It puts a whole lot less pressure on me to go out and find a job. And so instead, I can take all that energy and all that effort and I can marshal it towards focusing on my recovery, towards focusing on my mental health. And guess who can't do that? Jason can't do that. Because Jason has to spend all that energy and all that time trying to just meet his most basic needs. And that was my first clue that recovery wasn't just about effort, that recovery wasn't just about willpower or about desire. All of my friends desired to be happier and to be healthier and to be out of that bondage. It wasn't enough. What I realized is that these resources really seem to be the thing that were driving people's recovery. And then I got into graduate school and I learned there's actually a term for this. And so the fancy term I want to leave you with today is going to be recovery capital. And we'll unpack that a little bit more in a moment. But recovery capital, turns out I had it in spades. It turns out my recovery bank account was filled with assets that I could leverage to support my recovery. And Jason couldn't. Jason's trying to maintain his sobriety at the same time that he's working a job making $8.50 an hour and trying to dig his way out of restitution and court fees and probation costs. And that math don't math, right? And so that's when I came to understand that really recovery capital, these assets, are a lot more of a key to recovery than we previously understood. I'm going to skip over some pictures here just for the sake of time. There's a bunch of happy stuff here, so I'm sorry I'm skipping happy stuff, but we got to move. Okay, so here's what I want you to know. When I got out of treatment, I had been to nothing but abstinence-based, 12-step based treatment centers. And then when I got out, I went to a 12-step program. And what that meant was everyone that I knew who was in recovery was in 12-step abstinence-based recovery. And so I made the mistake that so many of us, including many clinicians, make, which is assuming that that's the sum total of recovery. That is the pathway of recovery, is you go to abstinence-based treatment and then you go to 12-step program and that's what you do. And as it turns out, that's not just one pathway of recovery, it's a minority pathway of recovery. And yet, when I got out of treatment, because all I knew is that recovery equals abstinence, and because abstinence had done such wonderful things in my life, in part as a consequence of my access to capital, I went around trying to get everyone sober. I went around just declaring to all of my friends who had addictions, if you'll just stop using, everything will fall into place. All will be well. This is a super violent image, and I'm sorry for that. But I used to joke and tell people that I went around with my hammer of abstinence gospel, you know? And it's like, you've heard the phrase, if all you have is a hammer, then every problem looks like a nail, right? And the only tool in my tool belt was abstinence-based 12-step recovery. And so I went around coercing and imposing it on everybody. And so I tell you that to tell you that this is me in 2015. Um, I want to make sure to start in a little spirit of humility because I'm going to be very critical of the way, honestly, clinically, that we tend to approach addressing substance use disorders. And I want to be careful that I don't take a posture like I'm wagging my finger or like I know better than everyone else. This is me in 2015, totally ignoring all of the assets that would predict recovery and just demanding that people get sober, right? And so this is the tension that I want us to explore today. But first, three lessons to make clear that I needed to learn in order to make sense of this. The first is that addiction is a chronic disorder. It's not an acute disorder, it's a chronic disorder. And that means consequently, recovery is not an event. Recovery is a process. Recovery is nonlinear. Recovery is fits and starts and two steps forward and one step back. It means relapse is a part of recovery. And some of my colleagues bristle when I say that, but they say, look, we don't want to normalize relapse. And all I know to say is relapse is normal. If you look at rates of recurrence for any other chronic disorder like diabetes or hypertension or COPD, they're always like 40 to 60%. And that's roughly what we see with substance use disorders as well. And number two, because recovery is a process and not an event, it's not abstinence. It's not the moment of abstaining that allows people to recover. It's these assets that improve quality of life that drive recovery. And because it's not abstinence that drives recovery, harm reduction is actually a really robust pathway of recovery. So we're going to unpack all this, I promise. First, in order to make the case that addiction is a chronic disorder and that recovery is a process and not an event, I'm going to do the tiniest little bit of brain science. I'm guessing you all know that this is not brain science. This is an egg in a frying pan, and it is the least helpful illustration of your brain on drugs. This is a much more helpful illustration. This is a kind of neuroimaging. It's a PET scan, right? Positron emission tomography. We're looking at dopamine receptor availability in the brain. The addiction 101 version of this is that through repeated exposure to drug use in the brain, every time you get those spikes in dopamine, through chronic exposure, dopamine actually downregulates as your brain tries to compensate. And so that's what you see. The brain on the far left is the normal, healthy control brain. The brain in the middle is the brain of somebody who's addicted to methamphetamine. And you can see that all that dopamine is downregulated. There's actually a special neurological term to describe, or neuroscientific term to describe that brain in the middle. And this is so pretentious to say out loud, but it's my favorite word in the English language. And that word is anhedonia. An means not, and hedonia means pleasure. So anhedonia means no pleasure. And that's exactly what it is to have an addicted brain. Sometimes people ask me about what's it like, the lived experience of addiction. And obviously, there are so many adjectives that describe, so many of those experiences. But for me, anhedonia, that state of being, that state of misery, of the inability to experience pleasure is the best way to describe addiction. But here's what I really want to show you is I'm playing a trick on you. And it's a significant trick because that brain in the middle is not actually the brain of someone who's addicted. That's actually the brain of someone who was addicted to methamphetamine and now they just graduated a 30-day treatment center, right? By the way, what does the term graduation imply to you all? I mean, my daughter graduates middle school. It means she's done. She's not ever going back to middle school again, right? She's finished. The implication here is that you've gone to your 30-day treatment center, you've stayed abstinent for 30 days, you're done. You're finished, you're cured, right? Sometimes we say cheeky things like, don't think, don't drink, and go to meetings, like that's going to be all the support you need. And yet, look at this brain, you all. That is like addiction manifest right there. That brain is completely and utterly vulnerable to relapse. And so this is the mistake that we make. We have a chronic disorder that we treat on an acute 30-day basis. And on day 31, when we release people back into the community, most often back into the situations, the environments that made them sick in the first place, and they're doing it with brains that are nowhere near sufficiently restored. And so the hopeful part is the brain on the far right, the brain of someone who was addicted to meth. Now they're 2 years in recovery. And what you notice is after 2 years, that brain is beginning to restore in a meaningful way. That brain looks a lot more like an approximation of the healthy control brain. And so if I lost you somewhere along the way, I mean, certainly I'm not a neuroscientist, so if I did, it's my fault. But the long and short of it is this. The changes that occur in the brain as a consequence of addiction are long-term protracted changes. And that means that the simple cessation of drug use is not enough to arrest addiction, that this brain has to have time to repair. And so, how do we support that process over time? We do that by providing the recovery capital that people need. And so, if recovery capital sounds fancy, think about other times you've heard the word capital: social capital, financial capital, capital's resources. So, recovery capital is recovery resources. And it's a really expansive bird's eye view of thinking about all of the resources, the sum total of resources inside of a person and outside of a person that they might use to support their recovery. So some of them are really obvious: housing, employment, transportation, right? Access to healthcare. I mean, some of those are like gimmies. Maybe the time and place in which a person's trying to recover, which is going to determine stigma. It's going to determine access to evidence-based approaches. For instance, in rural parts of Kentucky, there's a real negative view, pejorative view of medications for opioid use disorder. So definitely time and place there is going to determine, what kind of capital you have access to. But I also like to put recovery capital next to Maslow's hierarchy. And I'm willing to bet all of you remember Maslow. Remember that Maslow said in order to reach your full potential, your needs have to be met in order, right? Like you don't send your kid to school in the morning without breakfast in their belly and without a good night's rest and expect them to perform well and expect them to behave, right? Those are unreasonable expectations to expect them to perform this higher order work when you haven't met their foundational needs, right? And the same thing applies with people who use drugs. This is kind of a graphic example, but when I was standing on the on-ramp to Highway 35 and holding a cardboard sign that said homeless and hungry, you wouldn't have pulled up next to me in your fancy SUV and said, "Hey, buddy, you just need some self-esteem. Hang in there," I'll grant you that I did need some self-esteem, but I can't begin to build self-esteem until I have a nutritious meal in my belly, until I have somewhere to sleep other than under a bridge, until I do something to address the abscess that's forming at the injection site on my arm. How am I ever going to begin to contemplate a really difficult long-term change like recovery when I haven't even addressed the abscess on my arm, right? And so recovery capital, the reason I like to put recovery capital next to Maslow is because it reminds us that people who use drugs are people first. And so often when we're working with people who use drugs, sometimes we treat them like they're alien and like they have some really wild subset of needs, or they need some specialty interventions. And most often what they're lacking are the most foundational, obvious needs, right? The reason that recovery capital over here leads to remission or long-term recovery over here is because it reduces stress. And when we say reduces stress, we don't mean like, oh boy, I had a stressful day at work. We're talking about that really meaningful kind of biopsychosocial stress. You're a single parent who is working two jobs. You're trying to put food on the table. You're worried about getting evicted. And so your cortisol levels are persistently elevated. And as a consequence, you're in fight or flight mode all the time. Your ability to be a good employer, to be a good partner, to be a good parent is all compromised. And it's not because you're a bad employee. It's not because you're a bad parent. It's not because you're a bad partner. It's because you're experiencing such disproportionate stress, right? And so what recovery capital does by virtue of improving housing, improving relationships, whatever it is, it reduces this stress, which puts people in a better position for recovery, all right? So far, I probably haven't, even if you like recovery capital is a new term for you, most of what I'm saying really isn't profound, at least so far. What I'm saying is people need resources, right? People need access to these assets. But that maybe seem obvious, but now what I want to do is I want to pose a question that at first is going to seem oddly specific, all right? And then when we start to unpack some of these examples, I think you're going to see why this is such a significant tension. The question is kind of a chicken and an egg problem. Okay, so we know recovery capital is important. We know these resources are important: housing, mental health care, et cetera. But when do we start to provide them for the folks that we work with? Should we get them recovery capital first, or should we get them sober first so that then they can be a good steward of those resources? And I want you to think about that for just a second. And I want to suggest, I've never been to Hawaii, but I want to suggest that in your community, probably like mine, certainly like the contiguous 48 states, we've answered that question in all these communities, and we've answered that question by deciding that people need to get abstinent first. We've decided that people earn access to these assets, they earn access to recovery capital, and the way that they'll earn that access is with abstinence. And so I'm going to give you some examples. Housing is the preeminent example. We don't have housing for people who use drugs in my community. It absolutely does not exist. The closest thing that we have are emergency shelters. But you all are probably aware that many emergency shelters and homeless shelters have drug and alcohol free policies, many of which are zero tolerance, to the extent that if you violate that policy, you can be permanently banned from the emergency shelter. And I know this as a matter of experiential fact because it's happened to quite a few members of quite a few of our participants at Voices of Hope. And I would just assert for you that these aren't people who are being kicked out because they're bad or because they're rebellious or because they're unwilling to follow rules. They're people who have substance use disorders, which means by definition, they're necessarily going to be using and possessing drugs, right? We have sober living, but sober living is not a place you can go to become sober. It's a place you go if you're abstinent the day you walk through the door, right? So let's do a little thought experiment. I'm going to go back for a second. Let's imagine that I'm this brain in the middle, because indeed I was at one time. And I just graduated my 7th 30-day treatment center. I really did do that, okay? And after a 30-day treatment center, I've relapsed 6 times before. And so this time I'm starting to learn from my own experience. And I go, you know what? Even though I don't understand this long-term brain science, I have this intuitive sense that I need longer-term support. And so I decide that I'm going to opt into a halfway house. I think most clinicians would agree that's a good move, right? We're increasing my odds of sustaining long-term recovery. And so the day that I check into that halfway house or that sober living, I'm abstinent because heck, I just graduated an abstinence-based 30-day treatment center, right? But let's say 2 days later, this brain that I have does exactly what that brain is vulnerable to do. And it experiences a relapse. What do you think is going to be the response of the halfway house? They're going to kick me out. So let's run kicking me out through the prism of Maslow. So at this time that I'm already experiencing, I'm experiencing a relapse. I'm already experiencing disproportionate biopsychosocial stress. And then your response to that is going to be to deprive me of one of the most foundational aspects of my health and wellness, to take away my housing, right? Most often we do that in an effort to expedite the rush to rock bottom, which is something I'll say some more about in a moment as well. Caregiving, we tell family members and concerned others, don't enable, don't enable, don't enable. And at the same time, there's this huge, robust, growing body of research that suggests that family support is critical. When family members are involved, their loved ones are more likely to access treatment, they're more likely to complete treatment, they're more likely to engage with aftercare services following treatment. And yet, we've so pathologized family support that family members don't know the difference between enabling and supporting. And so what family members do is they won't give their kids a bed, they won't give their kids a shower, they won't give their kids a meal. In some cases, they won't give their kids an I love you text because they've been taught that they need to detach with love, that their kids need to get abstinent first before they show them an expression of love and support. It's backwards. And then those might be a little bit more abstract for you all, but as clinicians, I think this is the example that helps drive the point home most clearly. It's most apropos to your work. At the clinic where I was trained at our family center, University of Kentucky, we used to have a policy that said if drug use was mentioned at intake, even if it wasn't the primary presenting problem, so families could be presenting for divorce or conflict with an adolescent or whatever, but if drug use was mentioned at all, our policy said that individual has to go and complete treatment prior to participating with us in therapy. And if you think, the old school, kind of obsolete clinical logic there is we can't have somebody who's addicted in our sessions. They're going to torpedo all of our sessions. So what we're going to do is we're going to get them sober first, and then they can come and benefit from therapy. And that's fine. I suppose there's a clinical logic to it, but I want you to think about what was the real world impact of that policy. I mean, do you think that all these folks who use drugs in my community skipped off to treatment and got abstinent so that they could come to family therapy with me? I mean, of course not, right? What it meant was we created a systemic barrier. We basically said we don't serve families who use drugs. We don't know how to serve families who use drugs. What you need to do is you need to figure out how to get abstinent on your own. And once you figure that out, then you can come back to us for services, The same thing happens in domestic violence shelters where Um, we have kind of the same obsessive focus on abstinence. And so women who are victims of domestic violence, who are using substances in part as a consequence of their victimization, get kicked out of shelters because they can't observe these zero tolerance drug and alcohol free policies. And of course they can't. They have substance use disorders, right? And then the last example I'll give here, kind of the most ridiculous example, comes from my favorite recovery thinker in the world. His name's William White. And 20 years ago now, in 2005, he wrote a paper, and verbatim, the title of this paper is It's Time to Stop Kicking People Out of Addiction Treatment. And this is what he argued. He said substance use disorder is the only disorder for which the patient is blamed for the failure of the treatment. And that is so true. Every single time I relapsed, they pointed the finger at me. What did I do wrong? No one ever stopped to ask if maybe there was a flaw in this 30-day treatment I was being offered for this condition that's chronic in my brain, right? And so here's another way of saying that. When I go to treatment, what I'm implicitly acknowledging is I can't control my drug use. I can't stop, you know? And so I come to you one day and I say, look, treatment provider, I can't stop. I need your help. And so you go, you know what? I'm glad you came to my door here because that's exactly what we do here. We help people stop, right? And then 2 days later, indeed, I can't stop. And let's say I experience a relapse. Maybe I brought some heroin in with me or whatever. What do you think is going to be the response of the treatment center? They kick me out for non-compliance or whatever kind of pathologized, medicalized term you want to use. When here's another way of saying that. I came to you and I said, I can't control my drug use. And you said, let me help you with that. And then 2 days later, when I couldn't control my drug use, you went, oh my God, you can't control your drug use. Get the heck out of our institution. And when you figure out how to control your drug use, you can come back to us for treatment. It's backwards, right? It's demanding, it's like coercing abstinence first without addressing any of the biopsychosocial needs, without addressing the mental health, without addressing the trauma, without addressing any of the actual drivers of the addiction, right? If in some ways it's like people who use drugs are not their problem, drugs are their solution, right? And so taking away the drugs doesn't solve the problem. There has to be something in its place. So what I'm suggesting is if you believe in rock bottom, if you believe that people need to get abstinent first before we provide them with any of these services, because if you think that we're, giving them housing or care and support or mental health services is just enabling, then you don't believe in Maslow at all. You got Maslow upside down. And I always want to make the point that I'm not just flipping this upside down to be cheeky and be funny. I really do think this is a helpful illustration of the precarity that characterizes the way that we approach recovery today. This is what, if clinically your ability to help patients rests entirely on abstinence and abstinence alone, this is how precarious their recovery looks in my mind. Because it means what you're asking them to do is to recover from their addictions. I don't know if you all can see my cursor here. You're asking them to recover from their addictions without the benefit of all of the resources that research says would help them recover from their addictions. Right? Oh, housing would help. We'll withhold that until you get abstinent. Oh, mental health services would help. We'll withhold that until you get abstinent. You can go on down this ridiculous list. So here's what some of the experts had to say about rock bottom. Keith Humphreys was the senior advisor to the Obama White House from the National Office of Drug Control Policy. And he said, it's remarkable that people believe what's needed is more punishment. If punishment worked, nobody would be addicted. It's a pretty punishing experience. And every time I read that, I think of the neuroimaging, and I think of that brain in the middle, and I think of anhedonia, and I think there is nothing that my parents could do to me, nothing the criminal legal system could do to me, nothing the general public could do to me that was ever as bad as anhedonia. It was ever as bad as what my brain did to me. And if that punishment wasn't enough to make me reverse course, then no amount of punishment will be. And this is part of why I totally reject any kind of punitive carceral approach to addiction, because at its most fundamental level, what an addiction is continuing to engage in a behavior despite the consequences. So let's say that again, engaging in the behavior despite the consequences. So why on earth would we think that more and more and more consequences would change the behavior? It belies, the very definition of addiction. And then I alluded to William White earlier, my favorite. This is the moment that he describes when one of his colleagues grabs him by the shoulders, literally, and shakes him awake. And he says, Bill, you're not getting it. My clients don't hit bottom. My clients live on the bottom. Their capacities for physical and emotional pain are beyond your comprehension. If we wait for them to hit bottom, they'll die. The issue of engaging them is not an absence of pain, it's an absence of hope. And every time I read this, I think of Caleb, who we've worked with at Voices of Hope. Caleb's probably in his sixth. It's hard to say how old he is because he's experienced homelessness for many years. He's got an alcohol use disorder. He's an older gentleman. And I can just imagine that if I was really an ardent believer in rock bottom, if that was my theory of change, if that's my understanding of how people recover from addictions, then what I'll do is I'll go under that bridge and with a straight face, I'll look Caleb in the eye and I'll say, Caleb, the reason you continue to drink is because you haven't suffered enough yet. And I always tell people, like, I am not trying to tell you how to feel, but I'd like to think that for you, like for me, that just violates something in you. That there's just a part of you that recognizes that Caleb deals with so much pain and suffering on a daily basis that's clearly not the thing that's going to drive him towards recovery. What he needs is some hope. What he needs is some help, right? And so this leads us to the treatment and harm reduction gap, which I want to describe for you. So even though I've put this slide up, do me a favor and don't look at it yet, because I want to give you some context first. So year after year, the National Survey on Drug Use and Health is our big epidemiological survey of drug use in the United States. According to the National Survey on Drug Use and Health, year after year, there's an 80 to 90% treatment gap for substance use disorder. And you all have probably heard of the treatment gap before, right? It simply suggests that 80 to 90% of people with substance use disorders are not getting the treatment that they need each year. And most often, when we talk about the treatment gap, we characterize it as a problem of treatment availability or as a problem of treatment accessibility. And as a consequence, what we do in response is fund millions and millions of dollars of more and more treatment centers and more treatment beds, right? Because obviously, if people who need treatment aren't getting it, we need to build more treatment centers. But here's what's so interesting. If you do a deeper dive on those data and you ask the 90%, the 80 to 90% who stand in the treatment gap, you ask them in a very straightforward way, how come you didn't get treatment this year? Is it because it wasn't available? Is it because you couldn't access it? And that's what you're seeing reflected on this graph. 95% of people who didn't access treatment, 95%, the lion's share of folks who exist in that treatment gap were not interested in the treatment options that were available. It wasn't a problem of treatment availability. It wasn't a problem of treatment accessibility. It's a problem of treatment acceptability. Acceptability. It's unacceptable to people who use drugs because our entire treatment apparatus is designed, first of all, to address a chronic disorder in 30-day bits, which is a mismatch that some people who use drugs intuitively recognize. But number two, it's entirely predicated on abstinence and abstinence alone. And many people who use drugs have had enough experiences of trying to just coerce themselves or trying on willpower alone to force abstinence, and it didn't work. And so as a consequence, they're unwilling to engage with treatment. So, treatment availability, still a little bit of a problem in some places. I don't want to diminish that. Treatment accessibility, certainly still a problem in some places. I don't want to diminish that. But what is driving the treatment gap, what is primarily responsible for so many people in our communities not getting help, is that they don't like the very rigid, singular pathway that we have offered them, right? And so this is where harm reduction offers a different way forward. So I'm going to skip some slides here, again, just for the sake of time. So sorry. Just to say a little bit about harm reduction, and I'm going to connect it to recovery, and then I'll take your questions, okay? First of all, harm reduction is something that we all do every day. I drove to a conference this morning that was about 6 miles from my house. And even though every time I get behind the wheel of a car, there's an inherent risk of harm, I was not going to walk my happy ass 6 miles to this conference. Okay. So I get into my car and I put on my seatbelt. And as I drive, I mostly observe the speed limits, right? That's harm reduction. Seatbelts, sunscreens, these are kind of maybe abstract examples. If you're trying to lose weight, the abstinence-based approach might be to cut sugar entirely, but maybe you want to have a Diet Coke, right? That's a form of harm reduction. The most apropos example of harm reduction is abstinence-based sex education. You all probably know that for decades in this country, we used implemented abstinence-based sex education. We tried to show kids scary pictures of STIs. We tried scare tactics. We told them, "Don't have sex, you'll get pregnant and die." And it turns out it just wasn't effective. It turns out that hormones were stronger and that it was an uncomfortable fact, but a fact nonetheless, that some kids were having sex. And so rather than condemn it, rather than deny it, rather than pretend it wasn't happening, at some point we decided we have to reckon with that reality. We have to reckon with that uncomfortable fact. And we started equipping young people with the ability to mitigate the harms of sexual activity, right? That shift hasn't happened with people who use drugs. We have an abstinence-based approach that there's this uncomfortable reality that people use drugs in our communities, and we're unwilling to acknowledge it. Instead, we want to ignore it, we want to condemn it, we want to deny it. And what harm reduction does is harm reduction lives in the reality that, like it or not, some people use drugs. And that's at its foundation, what makes harm reduction so different than the prohibitionist approach, the abstinence only approach, the war on drugs approach. That prohibitionist war on drugs approach, its stated goal is to eradicate drugs from our communities, right? Drug-free communities. First of all, I think physicians in general would agree we don't want drug-free communities because lots of drugs are very good, lots of medicines are very good. But number two, it's the most ridiculous notion I've ever heard in my life. We can't keep drugs out of jails and prisons. If you can't keep drugs out of jails and prisons that are locked down, how are you going to keep them out of your community, right? It's just an uncomfortable fact that drugs and drug use exist, and harm reduction chooses to contend with that reality. And so I want to talk really briefly about two different kinds of harm reduction: lowercase and uppercase. So lowercase harm reduction is probably the kind of harm reduction you're familiar with. It's the practical strategies that are aimed not at reducing drug use, but aimed at reducing the consequences of drug use, right? And then after that, I want to talk about harm reduction as a philosophy, capital HR, okay? So just to give you one really good example of lowercase harm reduction, you all might be familiar with the case of Scott County, Indiana. In, I think, 2014, there was an HIV epidemic. And I mean, it actually met the public health criteria for an epidemic. And it's an interesting reason why. There was a cohort of people who were snorting an opioid painkiller called Opana. And the pharmaceutical companies tried to devise an abuse deterrent formulation. And they're like, "Oh yeah, we're so smart now. When you try to crush it up and snort it, it melts and you can't snort it. It dissolves." But it turns out that people who use drugs are far too industrious for that. And so people who use drugs realized that while they couldn't crush it up and snort it anymore, what they could do is melt the film and inject it. And so the kind of unintended consequence of this policy shift was that overnight, a cohort of people who had been snorting pain pills started injecting pain pills. And that led to a ton of transmission of disease. And so the CDC commissioned a study to identify the communities across the United States that are at risk of the next HIV outbreak. And I can tell you, as a Kentuckian, 55 of those 220 communities are in my state. And so that drove the need for access to syringe service programs. So I went to our Senate Judiciary Committee and advocated for harm reduction measures like syringe service programs. And syringe service programs are such a perfect example of lowercase harm reduction because they're not intended to reduce drug use. They're not intended to connect people to treatment. What they're intended to do is to reduce the spread of infectious disease. And even if you have the most biased, horrible views on people who use drugs, even if you don't care a lick about people who use drugs, you still have a vested interest in having a syringe service program in your community because you don't want HIV and hepatitis C running rampant. You don't want your sexually active adolescents to be facing that threat, right? From a public health perspective, it's a no-brainer. But then, as it turns out, in addition to really effectively meeting that goal of reducing the incidence of disease, it also accomplishes a lot of other tasks too. So for instance, it means you're going to have fewer syringes on playgrounds because it's going to be more effective syringe disposal. It means police officers and first responders are going to get fewer sticks with syringes. And here's the one that I find most interesting. People who engage with syringe service programs are 6 times more likely to access treatment than those who don't. And so even though access to treatment and recovery may not be the stated goal of a syringe service program, It turns out it creates a really, really wide pathway into recovery. It turns out that these folks didn't need to start by getting abstinent. Instead, they could start with some harm reduction, with some recovery capital, and work their way to abstinence. But that's lowercase harm reduction. And with my last 5 minutes, I want to tell you about uppercase harm reduction. So I don't need to explain the stages of change to you all. This is awesome because you all are brilliant. You know what I'm talking about. So I want you to imagine these are our stages of change for substance use disorder. And so you can go ahead and locate all of your patients, all of your clients, all the folks you work with somewhere on this spectrum, right? Everybody in our community who uses drugs, everybody in our community with a substance use disorder is somewhere on this spectrum. Some are in denial, pre-contemplation, some are kind of ambivalent, they're kind of in contemplation, some are, all these different stages. Under our current model that demands abstinence, abstinence first, and complete, total, and perfect abstinence, we can only work with these folks right here. So when we ask the question, how come there's a treatment gap? And how come that treatment gap is so driven by the lack of treatment acceptability? That's what you're looking at right here. The advantage of harm reduction is that it spans the stages of change. Irrespective of where someone is in the stages of change, we can build a rapport with them. We can start to build recovery capital for them. We can reduce the harm of their drug use. We can reduce the harm of their drug use to other people. And all of those things are fertile soil for recovery. All of those things are positioning people for recovery. And that's even somebody who's way over here in pre-contemplation. And so with my last 5 minutes here, I want to tell you a story to just tie all this together. This is my favorite success story from Voices of Hope because, and I recognize you can't read this note. It's just a placeholder for me to tell you the story. But this is the best example of number one, what makes Voices of Hope special as a recovery community organization, but number two, of how harm reduction is not the opposite of recovery, how harm reduction is not for people who've given up on recovery, how harm reduction is a genuine, robust pathway of recovery. Okay. And this is a completely true story. So our sign out in front of our community center, we're on Broadway in downtown Lexington, and our sign out in front of our community center says Recovery Community Center. And as I've told you throughout my presentation today, most of the people in my community, when they hear the term recovery, what they hear in their head is abstinence, because they think that recovery just equals abstinence and nothing more, right? And so there's a woman who has an opioid use disorder. She's an IV drug user. She's experiencing homelessness, and she's pushing a shopping cart by our center every single day. We would literally see her pass by our front window every day. And every day she would read the sign that said Recovery Community Center, but in her mind, what she heard was Abstinence Center. And she's one of those 80 to 90% who stands in the treatment gap, who's not interested in abstinence today, right? For a variety of complicated reasons. And so day after day, she sees the sign and she just walks on by, pushes her cart on by and says, that's not for me, because they're just going to try to get me abstinent, try to force me to stop, right? And then one day, through word of mouth, she randomly heard that she could get her laundry done at Voices of Hope. We have a washer and a dryer that we offer to participants, and all that we ask in exchange is that they meet with a recovery coach. They don't have to commit to any kind of behavior change. They don't have to go to treatment. They don't have to do an assessment. They just chat. How's your day going for 5 minutes? Make a connection, build a little rapport, and then they can go do laundry for free. So she thought to herself, that's pretty low barrier. And so she starts coming into the center to do her laundry. And one of the things that I want to make abundantly clear is that this individual had no desire for behavior change related to her substance use at all. She's not coming to us because she wants to use less. She's not coming to us because she wants to go to treatment. She's not coming up to us because she wants access to methadone or buprenorphine. She's coming to us because she wants to do her laundry. Okay. And so on the first day, she puts her laundry in the washing machine, and there's an outlet right next, an electrical outlet right next to the laundry machine. And so she puts her clothes in the washer and then plugs her phone in and sits there and just plays on her phone the whole time. That's fine. So then the next week she comes in, she puts her laundry in the washer, she plugs up her phone to charge, and she goes and gets a cup of coffee. As far as I could tell, she didn't really interact with folks, but she went and got a cup of coffee. Fine. The third week, and this is a completely true story, okay? Hand on my heart. The third week, this woman comes in, she puts her laundry in the washer, she plugs up her phone to charge. She goes and gets a cup of coffee. She starts interacting with a couple people, and she wanders out to the smoking pad out back and starts smoking a cigarette. And out of the clear blue sky, she cocks her head and she turns to the recovery coach and she says, "Hey, if I wanted to get into treatment, could you get me into treatment?" The recovery coach is like, "Girl, you want to get into treatment? We'll have you there in an hour. Like, that's easy." And that's exactly what they did. And even though, as you can tell, I don't prioritize abstinence-based recovery above any other form of recovery, I find it fitting and ironic that that individual, that woman, is now 2 years in completely abstinence-based recovery. And here's why I find it so ironic. See if this makes sense to you. If we were like everyone else, if we didn't use the harm reduction approach, if we had said, if the moment she walked through our doors, we had said in earnest, "Hey, we can get you into treatment right now. We can help you get sober. We mean well," what she would have done is she would have tucked tail and run the other direction because she wasn't in that stage of change, right? What harm reduction allowed us to do, instead of coercing something upon her, it allowed us to respect her autonomy and her agency. It allowed us to reduce harm, to build some capital, to build some social connections. And that was the fertile ground on which her recovery began, not her abstinence. It just so happens that her recovery eventuated in complete abstinence, and that's fantastic for her. Certainly, abstinence is associated with the greatest gains in quality of life in recovery. But it's my favorite example that harm reduction is a massive, robust pathway into recovery. And yet, when we demand abstinence and abstinence alone, we create that treatment gap. We cut off access to 80 to 90% of people who aren't interested in complete, total, and perfect abstinence. There is so much more that I want to say, but I know that I go on, and I want to make sure to answer questions if we have any. So let me stop here and take any questions if you have them. Also offer my email in case you want to correspond that way or want me to dig up some research for you or something like that.
No, we just want you to move to Hawaii and start a center here.
I would love it. I wonder if you all have any recovery community centers in Hawaii.
We
And when
do.
I say that, that a recovery community organization, an RCO, is a specific
Yeah,
kind.
we do. We have Hawaii Health and Harm Reduction, and then we have some on the Big Island. Um, they're on the top floor of a building. I don't see them, walking by. Anybody
Yes.
know of a recovery community center? Yeah, I mean, that's a great idea. We've talked about, oh, what was it? H4. The governor was going to do over by IHS. Oh, you can do your laundry there. So yes, you can go into this four-story building and they have some well, they have some shelters. They have um, uh, lockers. You can do your laundry, and they have medical there too. I haven't been there lately. Resource center. Um, Punavai rest stop is like what you explained. Showers, washers. That's
Yeah.
nice. But not enough. I mean, these should be just everywhere you go, right?
And part of the reason they should be, this is just another point to emphasize about the treatment gap, is because we're marshaling all of our resources towards abstinence only treatment, it means 90% of our resources are serving 10% of the population. And it
Mhm.
means 10% of our resources are serving the 90% in the gap who happen to also be the most vulnerable, the people with the worst social determinants of health, the most trauma histories. And so in that way, we've created a system that really serves the haves and further perpetuates kind of discrimination against the have-nots. So I'm so excited. I just pulled up the website for Hawaii Health and Harm Reduction Center, and it's amazing. It's
Yeah, they're great. Um,
We actually
but
have a harm reduction conference coming up in January in Hawaii. We've had one annually. I forget how we've had it. And Hawaii has been a very strong proponent of harm reduction and needle exchange for over 30 years. So it's really positive to hear how strong your convictions are and building that program up in Kentucky. Thank you
yeah,
for sharing. That was a very powerful presentation. I really appreciated it. Thank you.
yeah.
And
Thank
yes,
you
please come
for
to
that,
Hawaii.
Rodney. I had the same sense that Hawaii would be much more progressive as it comes to harm reduction and some of these approaches, not just sort of like politically, but even culturally. I can see that there are some maybe cultural norms and values that align better with harm reduction in that way. Um, but yeah, we still have a long way to go in Kentucky.
And our 12-step programs are still split. I guess they have discussions and meetings about, oh, you're not really sober if you're on harm reduction medications, whatever, they're getting there. But what bothers me here is that in your story, you could get her into treatment in an hour. We can't do that. I mean, there
Mm,
just aren't treatment beds,
yeah.
we can bring her in the door, and we actually have mobile showers that go out to different places and mobile clinics, but we cannot get somebody into treatment. And then in order to go into treatment, I've heard you have to have something in your system. So even if you are abstinent right then, you got to drink a beer because otherwise you're not getting into treatment because, oh, then you don't need it.
Kelly, I've
You can,
been through that. I drove somebody an hour and a half west to Louisville to treatment. And when we got to the door, they tested negative because, of course, they did because we had just detoxed them and they said that they needed to test positive. And I threw a fit and I said, "Do you want us to go inject heroin in your parking lot? What are you talking about? It's crazy.
Mhm.
It's crazy."
It is. So wonderful as always. You are one of those speakers that when I hear you give a talk, I run after to try and get you to
Oh,
Hawaii. So I'm glad a lot of our chat agrees with that. Let's see, Jennifer says our Maui treatment locations are also not ADA. Oh my goodness. Yeah, so it's so hard to get people what they need. Um, and yes, our folks get kicked out of homeless shelters. Well, if they have their dog with them, that's not allowed, medicate, anyway. Yes. Caroline says we are just very limited in Hawaii. We only have one detox center, and if no beds are available for treatment, they go back to the streets and, of
wow.
course, relapse. Yeah, it's challenging. But thank you so much, Alex.
Absolutely.
I just love how you just speak from the heart and you just care,
Yeah.
it's so great. So hopefully we can have you speak again, and maybe we can have H3RC talk with you and see, maybe get ideas because what you're doing there is wonderful and what they're doing here is wonderful, but they're a different wonderful maybe. Maybe
Yeah.
we can get some
Yes.
sharing of ideas. All right.
Yeah. No, that sounds wonderful. I'd love to learn from you all. Sounds great.
Yeah. Thank you so much. And what do we have next week?
We
I can't.
have the Heat and the Pacific Islands with Dr. Jacob Lee.
Oh, the heat. Oh, okay.
Yeah.
Oh, Diane says it's a full-time job having addiction, jail history, houselessness, etc. Yeah, that's true.
Yeah.
More than one full-time job.
Right.
All right. Thank you so much,
Thank you.
Alex.
Take care.
Wonderful. Take a look at the chat. All the mahalos are coming in. So
Awesome. Thank you. Mahalo.
mahalos for the day. And I'll see folks next week.
That's great.
Right. Bye.